really great to be here, and it's an honor to be here also with my parents who are on the faculty at Stanford. So it's a mixed blessing having two professors as parents. It always makes for interesting dinner table conversation. Getting a word in edgewise is a challenge. Getting a short answer to a question is a challenge. But I do feel really grateful that they're here, and thank you for that kind introduction. And thank you to my husband who's home taking care of our 4 young children so I can be here today. I'm going to talk about today the 90% of the world's children who live in developing countries. So you're probably all very well aware of the risks of poverty in the United States. For example, larger family size, poor housing, and all of these conditions are really exacerbated in developing countries, where you have lack of sanitation, lack of clean water, exposure to infectious diseases and toxic metals, lack of access to school and healthcare centers. Now you can also recognize that severe malnutrition is a consequence of these conditions. About 10% of the world's children have severe malnutrition, and this is something, even if they experience therapeutic care, they experience long-term deficits as a consequence of severe malnutrition. There's another kind of malnutrition which is called stunting, which is considered to be invisible malnutrition. These two girls were part of my doctoral work. They live in a slum neighborhoods in Kathmandu. They're matched for school and for neighborhood, and they have the same birthday. The girl on the right is the median height for her age, and the girl on the left is about 3 or 4 standard deviations below the median height for her age. But if you saw her running around the playground, engaging with her friends in the classroom, you might not recognize that she was stunted or malnourished. But what we know is that stunting has serious long-term consequences. Stunting is associated with reduced cognitive development, poor motor skills, lower school achievement, difficulty making decisions, and then later in life with reduced participation in the workforce, lower wages, and risk of cardiovascular disease. We also know that over 40% of kids in developing countries are stunted, and in some countries, this is as high as 50%. 55% in Bangladesh, 56% in Cambodia, 50% in Guatemala, 2% in the United States. If you look at the population of the world and you look at kids who are stunted, you can see that these children are concentrated in particular geographic regions: Sub-Saharan Africa, Southeast Asia, and South America. You're looking here at a map which is highlighting areas with a high prevalence of stunting and a high degree of poverty, and labeling children as disadvantaged if they have either a high prevalence of stunting or of poverty, which is then contributing to their delayed development. So in terms of, here's the bad news, which is that in terms of development, stunting has a very narrow window of opportunity. What you're seeing here is, on the x-axis, from conception through death, a timeline of a lifespan. And what I'm showing you here is this first 1,000 days. This box here represents the area of possibility in terms of interventions that can affect stunting, because growth trajectory is generally determined by the age of 2, maybe 3. So linear growth is really determined by the age of 2 or 3. So in terms of thinking about interventions, you can think about supplementing during pregnancy, promoting breastfeeding, promoting complementary feeding. But after this window of opportunity, you really don't have opportunity to improve growth unless you wait until adolescence, when there's another period of rapid growth. The good news, though, is that there are areas such as receptive language and higher cognitive functions that have a longer period of development. So these have more of an opportunity to be amenable to interventions. And this diagram is a little out of date. We now know that these higher cognitive functions continue to develop for even longer than is portrayed here. So this is encouraging to me because my real interests are thinking about ways to intervene to improve outcomes for children. So what I'll talk about today is what kinds of economic and environmental and social factors shape early development, what are the effects of a conditional cash transfer program on early child development, and then how could this conditional cash transfer program be integrated with a parenting program that could improve its effectiveness for children. So I'll start with this first question of how do economic, environmental, and social factors shape early child development. And I'll show you 2 different studies that I think you would have had a chance to read or to look at, which the study in Madagascar and then the study with 4 countries. I'll start first by saying, what do we know about gradients? What do we know about preschool enrollment, for example, and how it differs by family wealth. So here we see data from 58 low and middle income countries. We aggregated this data as part of a recent Lancet review from several regions around the world, and this is showing the percentage of 3 and 4-year-olds who are enrolled and attending preschool, and it's split by quintile of income. So you see the percentage who are enrolled on the y-axis, the region along the x-axis, and then poor, second, middle, fourth richest, etc., in terms of family wealth. And what you can see is that regions differ not just in what the percentage of children enrolled is, but also in the difference between the lowest and the highest quintile. So in some regions it's very low, like South Asia, and it doesn't really vary much by wealth. But in another region, like the Caribbean, for example, you range from 31% to 75%, or Sub-Saharan Africa, which ranges from 4% to 35%. So you see big differences across different regions in terms of the disparity between the rich and the poor and who gets to attend preschool. So this is a way of documenting what we know about gradients in socioeconomic status, that there are gradients in terms of attending preschool. We also have some data that looks at language scores and how they differ by family wealth. So these are 4 countries who are all, children were measured age 5 to 6 years old. They were measured on the PPVT, which some of you may have used, the test of receptive vocabulary. And this is then, again, presenting the data as quintiles, 1, 2, 3, 4, and 5, and showing that you see a difference ranging from half a standard deviation difference between the richest and the poorest to 1.5 standard deviations between the richest and the poorest. So a question is, there's several questions that emerge from these data, these and the preschool enrollment, which is, what domains, is this language domain being affected by wealth? Are there other domains that are affected that are also show those same gradients? And how early do the gradients emerge? So this is what I'm going to tell you about 2 studies about the wealth gradient, looking at the wealth and education gradient. The first study was in Madagascar, which is a large scale, this was a baseline data from a large scale community nutrition intervention of approximately 3,000 kids, about 3 to 6 years old. And then the second study I'll tell you about is a multi-site study from Peru, Senegal, Indonesia, and India, which was an evaluation also of baseline data from a large scale water and sanitation intervention. In Madagascar, we collected data from May to July of 2007 in a representative sample of children from 150 communities. 82% of these children in the sample were from rural areas, and we did extensive pre-testing and collaboration with a local developmental psychologist. So our hypotheses, our questions, I should say, first, our questions were, this is a really poor country. What kind of gradients would there be in this kind of context? We see countries that have more heterogeneity in terms of wealth distribution, but Madagascar is pretty uniformly poor. Would we see those same kind of gradients? Do the gradients change over the age of 3 to 6 was another question. And were there any specific domains that seem to be more sensitive to wealth or education effects? The measures that we used were items from the Stanford Binet, the lighter scales, the Woodcock-Munoz, an adapted Stroop test, the PPVT, and the strengths and difficulties. We piloted a huge number of tests to figure out what would work most effectively, because much of it had to be translated into French and or into Malagasy. And we had to do some modifications. For example, in the Peabody test, here is a picture that usually looks like dollars and cents, which had to be converted to Ariari, the Malagasy form of currency. And then here, for example, we removed the staircase from the banister and just kept the banister. So the idea was to keep it as true to form as we could, but while removing things that would introduce a cultural bias into the test. In terms of the Stanford Binet, we actually could keep most of the materials to be used as intended. There were some things in terms of the pictures that we had, when a child had to describe a picture. When there was a picture of an automatic washing machine, we changed it to a traditional washboard. So we did an extensive, I'm happy to talk about this also in the question period to talk more about how we adapted the tests, but we did spend a lot of time making sure that the tests were accurate and were reflecting what we wanted them to. And in spite of the fact that we did spend a lot of time trying to make these tests as good as they could be, we were also limited. For example, with the Peabody test, we had to keep the original order of the items. And Ann Weber, who's a current postdoc here at Stanford, did part of her doctoral work looking at how much better the test would have been if we could have reordered the items. Because, for example, children who are 3 and 4 could answer number 72, but they couldn't answer number 6. So it had to do with what words they were learning earlier and what words they were learning later. But this is to say we did the best we could, and we know a lot more now. I'll tell you that much. Okay, so here we go. What did we find out in terms of our gradients? So what you see here is, this is really asking the first question, which is, well, how much of this variation in child performance are we really explaining by socioeconomic status? This is looking at the R-squared, the model R-squared, for these various subscales of measures of cognition and language, measures of anthropometry, and the measures of behavior. So this is essentially just asking this question of how much of the model are we really explaining? And what you see here is that this first gray line shows you this is just the sociodemographic variables, age, gender, birth order. And you're explaining, for example, almost 12% of receptive vocabulary, but only about 4% of visual spatial processing. Then this is adding maternal education to sociodemographic, or adding wealth to sociodemographic, or adding both. And what you can see is that if you add both, you're not really doing much better than wealth and sociodemographic in this case. And you see that same pattern here and here. And so one of our conclusions, or the way we interpreted this, was that wealth is really capturing a lot of the differences in socioeconomic status more than we saw from maternal education. It may be that there was more variation in wealth as opposed to maternal education, and they certainly weren't completely overlapping variables, but we did see that more was explained with wealth and maternal education. Now I will show you the gradients in language and executive function. So again, these are the same tests that you see along the bottom. And you see 2 y-axes. One is the age-adjusted score, and one is the magnitude of the coefficient. So the first finding that I'll talk about is using this y-axis here of the age-adjusted score. And this finding is that there's a stepwise benefit to child development outcomes based on increasing wealth quintile. We found a very similar pattern. I'm not showing you the graphs, but they're in the paper about maternal education. But you can see here this stepwise pattern. If you go from the 1st quintile to the 5th quintile across most of these domains, except for fluid reasoning, it looks pretty flat, and behavioral difficulties is flat. So that's the first finding that you can see here. The second finding presented in this graph using the right-hand y-axis is the magnitude of the coefficient. This was addressing our hypothesis that executive function and language outcomes would be more sensitive to socioeconomic status and or education. So wealth and or education. So what we did was to try and estimate the magnitude of the coefficient for receptive vocabulary for each one of these, and found that the biggest ones were in areas of language and executive function. So that would be receptive vocabulary and working memory. So we did find that areas of the brain, language and executive function were more sensitive to maternal education and to wealth, which fell in line with what we had hypothesized based on data coming out of the United States, and also brain analyses that are showing that those regions are more sensitive, possibly more sensitive to poverty. Our next question had to do with how the gradients change over time. So here we have across age, from age 3 to age 6 on the x-axis, and the difference between having no schooling, a parent with no schooling, and a parent with secondary and above. So what you're seeing here is a difference of 4 points at age 3, up to 17 points at age 6. And this also fit in with what we had hypothesized, which was that the gradient would widen over this time period. There was one study that in Ecuador that had shown a similar pattern of this widening. We found bigger widening. I'm showing you again one example. In the paper, you'll see many, many other examples of the gradients and showing the increases across those different tests that I showed you. So then you might have the question of is this just going to widen indefinitely, or is there some kind of plateau? So we've just started analyzing the longitudinal data. We now have information from these same kids when they're 7 to 10 years old. And this pattern, you can see here that this is the wealth findings, and this is the mother's education findings, and this is the Peabody across age. So this is the same test measured in the same group of kids from 3 to 6 and from 7 to 10, put together into a longitudinal analysis. And our reading of these data are that you see the widening at the beginning between 3 and 6, but that there's actually a plateau between 7 and 10. And similarly, when you're looking at the maternal education, it's not always significant, but that it does appear to be more of a plateau that's occurring from 7 to 10. And it may be that there's more heterogeneity in terms of the home environment for the children from 3 to 6 years old compared with the schooling environment that they would be in from 7 to 10. We don't have an explanation yet for why I would love to talk about this with all of you, for why there's this flattening of what looks like the gradient remains, but it remains around the same magnitude. And interestingly, last week I saw a presentation of the same team that had looked in Ecuador at the 3 to 6 year and showed the widening from 3 to 6 years old, and they have also found a plateau between 7 and 10, and then the continuing plateau from 10 to 13. So our kids are still 10 or 11, so we're not at the next follow-up stage yet. So these questions from Madagascar, these findings from Madagascar led us to ask, well, what is happening before this? So we're seeing this, what looks like a widening gradient till about the age of 6, and then possibly a plateau. What's happening before the age of 6? What's happening before they're even getting into preschool or being tested? And this was what the multi-country study allowed us to ask, which was what's happening in very early time period. So we used data from the World Bank's Water and Sanitation Program. Again, this was an opportunistic use of baseline data. I'm not showing you anything related to sanitation. I'm just showing you baseline data where we happen to have the child outcomes, and we also had socioeconomic status variables and family care indicators. And in this one, we have a little bit of a better sense of why wealth is related to child outcomes. So in this case, we used the child development measure, the EASQ, 3 subdomains of this test: the communication, gross motor, and personal social. Now this is an adapted ages and stages screening test. One risk with a true screening test is that you can end up hitting a ceiling because the ceiling and floor effects are very strong in the screening test, so we added questions above and we added questions below. Another risk of a maternal report test. I'm not saying I've ever done this, but some people might over-report what their children are able to do. So that's also a risk with maternal report, that parents aren't necessarily always very accurate in terms of what they know or are able to report about their children. So we also added several demonstration questions to turn this into kind of a hybrid test that's maternal report and also direct observation. This is an example of what the EASQ looks like. It's, for example, for 9 to 12-month-olds, you would ask the question, if you hold both hands just to balance your baby, does your baby support his own weight while standing? They have pictures, and we also use this test in Mexico and have had success with it in many different contexts. So descriptive statistics by country, what you can see here is really just looking at these countries. Now, I'm showing you here maternal schooling, for example, 4 years, 8 years, 7 years, 6 years. There's some striking differences. For example, Peru, fewer mothers were married. Household size is very similar except for Senegal. Child age, percentage male. You can see GNI per capita is very different across the countries. Same as prevalence of stunting, prevalence of wasting, and then human development index. So these countries are very different. They were selected for the water and sanitation study, and we've never really done anything with country level data to try and make comparisons across countries. So I'm not really able to comment on that because the study wasn't designed to do that. I'm just showing you patterns from each country in terms of child development and how those patterns relate to socioeconomic status. So here you see 4 graphs, each representing one country: Indonesia, India, Peru, and Senegal. And you're seeing the ASQ Z-score, norm score. And what you can see is that in some cases, for example, in India, the children start out pretty similar. Again, this is the richest quintile compared with the bottom 4 quintiles. They start out pretty similar, and then by 8 months, there's this gradient emergent. In Indonesia, it does look like the gradient is also emerging, but that between 8 and 12 months. In Peru, we're seeing what looks more like a parallel deficit across the first 2 years. And in Senegal also, that there's a clear deficit from the beginning that's just persisting over 2 years. So we're in the process now of analyzing the follow-up data to see whether these trends continue or whether there's differences as the children are 3 to 5 years old. We're in the process of analyzing those. Now, what we were able to do in this study was to look at parent stimulation measures. This was a scale called the Family Care Index that we had on all of these kids, which had to do with the availability of play materials in the home, activities with a parent or other adult, including reading books, singing songs, telling stories, and then outings that take a child outside the home. So our question was, how much of this wealth effect that we're seeing is due to some kind of parenting stimulation variable, and how much of it is due to something like health of the child? And what we found was that we're explaining up to 20, I would say 22 or 3% of the parental stimulation, of the wealth effect is explained by parental stimulation, whereas only 12% is explained by health. And we're using length for age as a proxy for health because it's kind of a cumulative status of well-being. If you combine both of them, you can explain up to 35% of the wealth effect. You see the wealth effect being explained on the top graph, and then the education effect being explained on the bottom. These numbers are the highest in Senegal, where we're explaining almost 60% of the variation, of the association between wealth and child development outcomes, explained with these 6 simple questions about book and play materials at home and whether or not the child was, not whether they were stunted or not, but what their length for age Z-score is. We explained less of the education effect by our parenting stimulation variable and our health variable. So what did we learn from these 2 studies? That children from relatively richer households or with better educated mothers do perform better across several domains, even in a really poor setting that we had hypothesized. We weren't sure if those gradients would exist in such a homogeneously poor environment. We also saw that differences between children from richer and poorer households get bigger across childhood, but may plateau. And again, we're in the process now of preparing that paper, so that's the story will be continued at some point. We saw that children from rich and poor households, the differences appear as early as 6 months in some contexts, and parental stimulation, books, toys, and outings can explain 20 to 40% of the associations between wealth and child outcomes. So this leads to the second question, which is, what can interventions do to improve child development? I started the talk by saying that we have this opportunity, whereas we don't necessarily have the opportunity with child height after the age of 2, we have the opportunity in terms of development. What can we do? What are some options? In terms of a theoretic framework for this question, we developed this model that we used in the Lancet series, which again has time on the x-axis, and thinking about trajectories, that our ideal trajectory is this green one with protective outweighing risk factors. And the adverse trajectory is when risk factors outweigh the protective factors. But our opportunity is when we can shift this trajectory from the red up to the green by having a reduction in risk factors or an increase in protective factors or some kind of intervention during a sensitive period. Now, as part of the Lancet series, we reviewed child development interventions and reviewed parenting programs, preschool and other center-based models, and promising directions. This was all in low and middle income countries. This is what I've spent 15 years studying conditional cash transfer programs, and it's called a promising direction. I felt kind of like, wait, don't we know more? Don't we know enough to be able to call it a real intervention? But you'll see that the data we have we don't have enough data from enough countries to be able to say enough about conditional cash transfer programs. So how do these programs work? I'm going to tell you just briefly what we know about parenting and preschool programs, and then I'll delve into the Mexican conditional cash transfer program. So how do parenting programs work? The best ones are when home visitors or promotoras or some kind of lady health worker, that's the one in Pakistan, come to the home and can engage with a caregiver, a child's caregiver, and engage with them and think about what the needs of that child are and what the caregiver's needs are, and to really tailor the message. They promote responsive parent-child interactions. They can increase attachment. They can encourage learning, encourage positive discipline, and promote better problem solving. But again, the parenting interventions that we have good models for and good evidence for are really the very high intensity, pretty expensive models of home visiting. And I'm going to tell you in the last section of the talk about a parenting program that's at scale, which is a much less intense kind of program. We also know that there's heterogeneous effects of parenting programs. For example, effects are largest when parents and children participate together. For example, if you have interventions where a child and a parent can practice what they're learning, rather than just teaching a parent how to interact with a child, those have bigger effect sizes in terms of outcomes on child development. We also know that the most disadvantaged children are targeted. Those kids can do better in parenting programs, and that the most effective programs use a structured evidence-based curriculum. And you'll see this is one of the features that was really prominent in the Mexican program that I'll tell you about. What we know about preschool is that preschool attendance is associated with higher scores on one or more measures of child development, and that there's the largest effects in terms of when there are higher quality preschool programs and ones that target the most disadvantaged children. But the kind of program I'm going to talk about today is a conditional cash transfer program. And these are programs that really are designed to pull children out of poverty, but are focused on transferring cash to households. Now, this works when cash transfers are conditioned. In addition to satisfying a certain criteria, for example, somebody lives in a certain neighborhood, or they live below a poverty threshold, or they attend a certain school. So there's a certain selection criteria, but then beneficiaries are regularly required to undertake some kind of pre-specified action. So CCTs are when governments transfer cash to families on the condition that families are making investments in human capital. So for example, sending kids to school regularly or taking kids to regular health and nutrition checkups. The idea with cash transfer programs is that they represent the state as a partner. This is how they really differentiate themselves from welfare programs. They differentiate themselves by saying, this is shared responsibility and respect, inevitably imply a reciprocal effort by poor families to link the benefits they receive to concrete actions on their part, and this is independent of technical considerations. So the goal with conditional cash transfer programs is that it's money going to the poor, but that there is also a reciprocal arrangement. Conditional cash transfer programs do try and address multiple factors, and they try and address multiple points in this graph, which you may have seen, which is looking at the rate of return to investment in human capital, that is suggesting that the earlier that you intervene, the more returns you have in terms of your investment. So the cash transfer program is trying to get at having parenting support, early nutrition and health, preschool programs, continued nutrition and health education, and incentives to make sure that kids stay in school. The way that cash transfer programs can work is through two major conceptual pathways. The first is through this cash that you have increased financial resources for a household, that those financial resources are going to increase parental investments, are going to potentially result in decreased emotional stress, which then will allow a parent to improve their ability to purchase basic needs such as food and shelter, and to provide more nurturing care, responsive, involved caring, parenting. Then through the conditions pathway, this is the mandatory participation in health and education activities. You have this direct provision of medical care, vaccines, growth monitoring, parasite control, and with the hope that by providing these health benefits, that parents also are able to focus more on their children and have increased knowledge in terms of what would improve child development. So Mexico was the second country in the world to institute a conditional cash transfer program after Brazil. They started them pretty much at the same time. And this model has been copied by dozens of countries now who are using cash transfer programs. Mexico is a large country that's a middle income country, which means it's dealing with stunting and low birth weight and wasting. Not so much wasting, but definitely low birth weight and stunting. But also dealing with this being at the nexus of nutrition transition, meaning you have kids who are simultaneously stunted and overweight. We found that 20% of 6-year-olds were overweight, and 10% of indigenous kids were stunted and overweight. And interestingly, I'm just analyzing some data from Peru showing a similar trend among indigenous children who are experiencing under and overnutrition simultaneously. So Mexico's conditional cash transfer program has several requirements that families must fulfill. For example, if children under 4 months, babies need to go to 3 checkups. From 4 to 23 months, they continue to get growth monitoring and immunizations, management of diarrhea, etc. Pregnant and lactating women need to go for checkups and nutritional supplementation. Postpartum women need to go for checkups, and then there's some prevention and control of hypertension and diabetes among the older population. So the study design was randomized in 1997. 506 communities were randomized to early versus late intervention. There was only an 18-month time gap between the early and the late intervention. And I'm telling you today not so much about this paper, which was the follow-up of 3.5 to 5-year-olds, but mostly focusing on the 8 to 10-year-old follow-up, which occurred in 2007. And one question you might ask yourself is, wow, these kids were recruited in 1997, now you're following them up. What was the difference between your follow-up group, the group that you could find, and the group that you couldn't? And we did find minimal differences in the follow-up group when you compared it to the non-follow-up group. There was only one difference, which was the number of people in the household, and the rest of the variables were matched. And then you might also ask yourself, what were the differences between randomization in that follow-up group? And what we found was that the randomization was effective. So even in the follow-up group, which represented about 60% of the original sample, they were still balanced by all of these baseline variables. For example, whether the father was present, about primary education, ethnic origin, etc. So what we have now is a 10-year follow-up looking at child development outcomes and asking what is the effect of this participation in a conditional cash transfer program in which families receive up to 25% increase in their income in exchange for participating in health care services, making sure their kids go to school, taking nutritional supplementation as necessary. Now, what we found was that when we compared the means at 8 to 10 years between the early randomized and the late randomized, there were no differences in means in height for age, BMI for age, verbal performance, or cognitive performance. The only difference we found in this comparison was in behavior problems, that there were fewer behavior problems in the group that had been in the program longer compared with the group that had been in the program later, that shorter period of time. I highlighted height for age to make sure to mention that the height for age Z-score, there was an effect on height for age in the kids of moms with no education. So it did seem that the program could affect growth, but only for the kids of moms with no education, suggesting that the program might be targeted at a lower level than the expected outcome, meaning that there was a benefit on height for age, but only with a certain very vulnerable group of kids of vulnerable moms. So our second question was, well, if we think back to that conceptual framework that I put up about the 2 pathways, you can see that a conditional cash transfer program could can give your household money. You're going to increase your household income by 25 or 30%. And in the bottom pathway, it means that there's the conditionalities, all the things you have to do. You have to stay in school, you have to take your nutrition supplementation, you have to go to all the prenatal checkups and the postnatal checkups and growth monitoring, etc. So our question was, what is the cash doing? Back to this question of what is money really doing? Why is wealth really associated with these outcomes? What's going on there? And so, in an analysis that I'm not going to go into, but is detailed in the paper, in both the Lancet 2009 and the 2008 paper, both of which use this approach, we looked at what the effect of just the cumulative cash transfers was on child outcomes. Now, this is where you see all of these variables as significant. So, to be clear of what this slide is saying, that for households who receive more cash, whose those children had higher height for age, higher verbal performance, higher cognitive performance, and reduced behavior problems. One of the reasons we think that the main intervention effect didn't have as much of an impact was that the control group was rolled in 18 months earlier than it was supposed to be. It was supposed to be a 3-year exposure period. It was only an 18-month exposure period. So then we were looking essentially in this analysis as a dose response. So essentially saying that the households are getting more cash even when you're controlling for many variables, including gender, parental, education, household ethnicity, all baseline characteristics. I think there are about 55 control variables in here. And still what we have is that the cumulative cash that a household has gotten is significantly associated with many of the children's outcomes. We also know from looking at this evaluation that the Mexican program reduces maternal depression. In this paper we showed about a 1.5 difference on the full depression scale of the CESD scores between the control and the treatment arm of the opioids. Similarly, when you look at a depression score with a cutoff, we saw 57% in the control group versus 50% in the treatment group that were had a depression score of over 16, which is the cutoff for a clinical depression of the CESD, risk for clinical depression in the US. And this score of 26 is considered also to be an appropriate score to use in Mexico, and we found 20% compared with 26%. Further benefits of the Oportunidades program are that it reduced child cortisol levels. And this effect was significant only in children of depressed mothers. So what we can see is that there really is, there are several program effects of this program, of the Oportunidades program. For example, we saw better child behavior scores in all children at both time points. We saw greater height for age in children of moms with no education, and we saw lower salivary cortisol in children, especially of depressed moms. And we also saw that when separating out the pathways, that we saw a cash effect that was significant for height for age, all cognitive and language function tests. We did also show that it was beneficial for body mass index in terms of protective factor, and reducing behavior problems at 3 to 5 years old and 8 to 10 years old. So this is great news, right? And what I want to show you now is the reason that this is also the unintended consequences of a great program like this are that we also have shown now that in terms of a program effect on adult obesity, that there was benefits of participating in the program, of significantly lower prevalence of obesity and hypertension, and significantly higher self-reported ability and activities. But that same cash effect that improved child development across all domains and across growth was actually associated in adults with increased BMI, increased obesity, and increased hypertension in adults. So this is a really critical question about how to think about a policy intervention. This is now a policy that's been used, like I mentioned, in dozens of countries around the world. It's been expanded to all parts of Mexico. It's in most Latin American countries have a conditional cash transfer program. Mayor Bloomberg had a trial of a conditional cash transfer program in New York. All over the world, and then we are also showing this cash effect of a potential really detrimental outcome for adults, especially in a country like Mexico, which has the second highest prevalence of obesity in the world, and the first highest prevalence of diabetes, even greater than the US. So what can we conclude about Mexico's CCT? Well, these long-term effects, as I mentioned, had reduced behavior problems and cortisol, improved growth in kids, reduced depressive symptoms, and the cash transfer component of the program is positively associated with almost all health and developmental outcomes. But it may not be good for all family members because the cash transfer was associated with worse outcomes in adults. And a question is really, should the program be adjusted, or should the cash transfer be reconsidered, reoriented, targeted, increased? So one response that the Mexican government had was, hey, look, if our goal is to improve child development, maybe we shouldn't just focus on cash and the health. Maybe we should focus on early child stimulation and giving parents support. So there's another program that was then overlaid onto the conditional cash transfer program called Educación Inicial, and that's what I'm going to show you how that study worked for the final portion of my talk. So this question here was, let's think about ways to improve child development that don't have to go through this cash pathway, since the cash pathway has these potential unintended consequences for other members of the household. So if we really want to focus on kids, let's think about adding a component of education for parents, which would then result in increased knowledge relating to appropriate child rearing and then improving outcomes. So what I'm going to show you now is data from a parenting support program that was overlaid in a randomized multi-arm trial on top of oportunidades, so that the baseline now comparison group is children who are just enrolled in a CCT program, the Mexican CCT program, or whether they were also enrolled in the parenting program on top of that. And I will show you how this works. So this is a program, Educación Inicial, which was very well developed in terms of a documented theory of change. They had materials, they have binders and binders full of materials that are for the promotoras to use in each community. They have systematically developed materials to help support them, and they focus on children 0 to 4 years old. They have group sessions 1 time a week. They follow the academic year. The promotoras are retrained every August, and they have many levels of supervision. The goal was really to add this parenting support component to a cash transfer program. And then this was the part which was trying to figure out whether CONAFE, Educación Inicial, should be required or whether it should be optional participation. The question was, from a policy perspective, should we make this one of those things that parents have to do? Like we make them go to get vaccinations and keep their kids in school. Should we do that with parenting support? Or should we allow parents to say, look, I want to do this or I don't want to do this, this is my choice. So we had 3 arms of randomization. The first being the cash transfer program alone. The second being where the cash transfer, where the CONAFE, Educación Inicial, was strongly encouraged, compulsory. And the third arm where participation was optional. And this entire study was stratified by indigenous status, because one of the big goals of this program was to reach out to people, particularly to families that were in the more remote regions, which is the indigenous population. I'm going to show you some examples of the materials that the promotoras received and used to show you some examples of what the messages were. So for example, when you're near your baby, you should be singing, talking to the baby. If you're putting them to bed, asking them questions. Did we just have a bath? Oh, you're going to sleep. Engaging with the baby and asking questions and acknowledging the fact that even if the baby's not responding, and that they are understanding you or learning from you. Similarly, there's messages for including dad and give me the diaper, baby's grunting, making cute little sounds. Oh look, we're gonna go see grandma. All kinds of ways to engage mom and baby and dad. And like I said, these are manuals and manuals full of educational opportunities for those promotoras to use with the families. They also organize it by month, by age group, so that, for example, you would see for a 6-month-old, what are some of the capabilities of a 6-month-old, what are things a 6-month-old could do, what are ways to cognitively stimulate the 6-month-old. I'm going to show you a video that I took of one of the group sessions so you can get a sense. Now, I want to remind you, what I said about those effective parenting programs is that the promotora, or whoever, the equivalent lady health worker, was going door to door. And not door to door. She was going to the houses with babies and doing one-on-one consultation, so she was able to respond. And I want you to remember that image of the one-on-one with this image of the group session. This is...
Dicen que el elefante es gordo, gordo, gordo. Yo soy muy flaquito.
She has a balloon in her stomach to pretend like she's pregnant.
Dicen que el elefante es gordo, gordo, gordo. Yo soy muy flaquito. ¿Qué le voy a hacer? Aplasta la pata con
So that was an example of the group session, which you can see is quite a bit different than if the same woman had come to your house and talked to you about what was going on with your baby and what you could be doing. But the idea is, with this program, that this is a scaled up program. So this is no longer an efficacy trial of a small size. This is a really big program that's much more manageable in terms of implementation, because women are coming to a community center, the promotora is coming to that same room and talking to a whole group of mothers about a particular topic. 1 week it might be 6-month-olds, 1 week it might be pregnancy and she's jumping around with a balloon in her shirt. 1 week it might be 4-year-olds, discipline, it could be anything. The promotora is following a guided, she's following this book of instructions, but she gets to pick who she's focusing on in any 1 week. It often includes the whole family. You can see here that even this day they were talking about musical instruments and making music with your children, but you can see much older kids here who are engaged, but also taking focus away from the smaller children. So in terms of what did we hypothesize that this program would do, I've got to tell you, I was a little nervous about whether it would have any effect on child development because it felt so dilute compared with what the other traditional parenting programs had done. In terms of this evaluation, we showed small, significant main effects, but these were not robust to the inclusion of covariates, and part of that reason is because we saw this major moderation effect of that baseline ASQ. So there were these significant and consistent positive effects for vulnerable children, those starting in the lowest quintile of cognitive performance that were robust to the inclusion of all the covariates. So to me, this program represents innovative thinking and a really great opportunity, and it's really one of the only programs that I know of that's been brought to scale in this way, but it really could be strengthened in terms of its improving impact on children's development. So in terms of conclusions for my talk in general, and what I'm thinking about in terms of next questions, what I hope I've showed you today is children living in poverty are at risk for inequality, and this is true even in homogeneously poor communities, and it also seems to be particularly true for domains relating to language and executive function, which we know to be crucially important. Following up questions for me are how early does this gradient start and what domains, and what are the implications later? So that's why I think we'll learn a lot when we can follow up those children for whom we have baseline information. Second, there are really a lot of several promising programs and policies targeting early child development, but how can we bring these programs to scale without compromising quality? This is an extremely relevant question because we know we have a lot of good evidence of how to do programs in a small, effective, and really highly consistent way. But how do we then turn it into a policy and that can be cost effective and isn't going to be as expensive as a one-on-one home visiting program, which is not as scalable as a community-based program. And last, I didn't talk as much about maternal depression today, but it's something that's really on my mind a lot in terms of thinking about a risk factor for children. I've done multiple studies in low and middle income countries where I'm looking at depression and finding very high prevalence of maternal depression. And my hope is to be able to think about how to address maternal depression as a source of improvement for children and also for their development, and to see whether social support could be as effective as direct early childhood programs. We're showing, for example, 50 to 60% of the women in rural Mexico having high prevalence of maternal depression, and we did show, for example, 1 or 2 points of improvement on the CESD scale as a result of the cash transfer program. But the question is whether some form of social support or some form of therapy or group support would be able to allow those mothers to then not just deal with their own depression, but then also be more sustaining caregivers for their children. So I'll just acknowledge the whole huge number of people who have allowed, this is all a team effort. All these studies were the multiple people. So I thank that all these co-authors and collaborators and research sources of research funding, and would love to have a discussion with you guys and take any questions that you might have. Thank you.
Would you like to field your own questions, or the floor is open?
Oh yeah, you can just blurt it out. Yeah.
Talking about how to scale it, and in particular how you get like that at home visit sort of experience, has there been any talk or any experimentation with sort of a buddy system of pairing like the low experienced and more skilled mothers with the younger, more experienced or less skilled mothers, just give that interaction could be?
But that's a great idea. I haven't seen that model. but I know there's several efforts, particularly in Latin America, to scale parenting programs. In Peru, for example, they're experimenting with having an arm which is doing community-based, really testing whether it needs to be the one-on-one home visit or whether, and then comparing that directly with community-based. But the pairing is an interesting idea. I haven't thought about that. Yeah, they're my mom. So. Yeah.
Yeah, okay. So that group intervention looked kind of chaotic, but it could have the effect of increasing social contact among moms who are isolated and perhaps depressed, and that in itself could be a kind of emergent property of it, that independent of what you're talking about in relation to children, that they could identify with others in the same.
Right, and I think
situation.
that's part of the reason that I'm so interested in looking at depression and social support, that you might see, but you might actually see benefits that have nothing to do with child development, or you might, in an intervention that had nothing to do with child development, just allowing the moms their own social support, that might result in better child development, even if you're not talking about kids at all.
So in the comparison between the more and less vulnerable kids in
Yeah.
that group, were you controlling for depression, or maybe?
I don't have those variables yet.
Yeah, okay, because maybe the more vulnerable,
Yeah.
it could have been mediated by.
That's true, absolutely, and I think I just got the data, I just got the depression and family care variables, and the social support and parenting stress, which I think will also be really interesting.
Looked like fun, the balloon.
I know, the balloon in the belly, she was funny. Yeah, and then I saw that question back there, yeah.
Yeah, was that person first? Go ahead.
Oh,
Okay.
yeah.
For the results of the conditional cash transfer, the value of the cash of the
Yes.
amount of money for adults, what is behind the amount of money to each adult? Because I'm wondering if there is any way that the adults are gaming the system to get more money.
Right, so you absolutely right that you're asking whether or not, what's determining how much money you get, and whether adults are figuring out how to game the system. So one of the ways that people consider about gaining, for the answer to your first question, which is is the amount determined? It has to do with the age and gender of your children, because more transfers are given for girls than for boys, and more transfers are given the longer the kids stay in school. So the most amount of transfer is given for a girl who's in high school, the next most for a boy who's in high school, then a girl who's in middle school, because they're trying to really encourage girls to stay in school. The second question, the biggest way that you could game a system like this is to have more babies. This is what people usually assume, that through increased fertility. So there's two things I can tell you about that. One is that that the maximum number of children who are supported by the program would be 3. So that it was not supposed to be a like, hey, let's have more babies kind of program. The second thing I'll tell you is that there was a really interesting analysis of that, Mexico's cash transfer program, and 3 other ones, including Honduras and 2 other countries, which I can't remember, that looked at fertility effects and didn't find that in any cash transfer program that it was influencing fertility or any kind of adverse gaming. Yeah.
So I found that result very curious about the contrasting outcomes between the effects of the cash transfer program on children and adults in terms of obesity. And one of the first questions that comes to mind for me, when you look at the ecology of what's available to be eaten in food environments, did that change at all in terms of what these families had access to buy in terms of fresh vegetables or protein? Or were they carbohydrate-laden diets? I mean, where, if you're hungry, you just buy more of that, but
Right.
it's not necessarily going to reduce your caloric intake. So I'm wondering if there was some change in the food access, or if that remained constant and it was just actually more, and if that might be an explanation for why you don't have results in a positive direction.
So you're saying that there would be a different access to food in those communities, or you're wondering if there would be a different access to
Or
food?
it's a different conceptualization, so you have more access to resources to buy to have more food on the table, so
Yes.
you don't go hungry. But there are certain foods that will increase your caloric intake, right?
Right.
Because they're, in many of these cultures, they're, we know with porridge and rice and, they're carbohydrate laden, because and they fill you up.
Right.
But they're not necessarily so I wonder if there was some thought or attention given to what was available in terms of the food source.
Yes, that's a great question, and I think that the food sources didn't change. This intervention never really addressed food sources or what was available in terms of for purchase. My best guess as to why there was improvements in child outcomes, which we have some suggestion based on some economic analysis of what was purchased, that there was an increased purchase in fruit and vegetables and also animal source foods, so meats, which would explain, that would be a plausible pathway for the children's outcomes. I think there are no strings attached to this money in the sense that it's just cash. You can spend it on anything. And we also know that the increase of cash was associated with increase of soda purchase and alcohol purchase. So it's possible that parents are making different decisions for themselves than they are for their children. Or they're learning more about nutrition for their children because the program is really focused on children. And they're learning different, they're worried about maximizing their child's potential for growth and cognition, but they're saying, hey, I'm gonna make a different decision for my own self. Yeah.
I'm curious as to how many of these results do you think are applicable to the U.S.? I remember hearing a lot about the whole Bloomberg sort of experiment when that came out, and my understanding is he threw a lot of money in that and was sort of surprising results. I don't know much about the outcomes of that, but I'm just curious.
I don't know because I've tried to get access to those results and I haven't been able to. So I can't answer. I don't know what the answer is in terms of what the program would be. I think what the program effects would be. I would say I think the program that looks the closest to this in terms of child outcomes is actually the WIC program. It's because it has vouchers that you can use for certain foods, healthy foods, and then there's requirement for growth monitoring, and there's a requirement for meeting with a nutritionist, and there's several requirements in that same kind of sense of conditionalities. What we do know is that the WIC program, in comparison with many other federal programs focused on kids, has been more effective in terms of birth weight and other outcomes than some of the pure cash programs.
So I was struck by the plateaus that you found in the data early on in your talk, and wonder if that's just running up against an essential stop in the way the brain can continue to be plastic in response to those efforts. So it could be that whichever group you're in, you're at a certain age, the plasticity amount simply drops. You can't continue to grow neurons or myelin sheaths in a way that will allow you to continue to grow on those curves.
I love that theory because it would explain. So I think I mean, yeah. So why don't you which kinds of brain functions would you would reach a stop at?
The Remain orphan studies, for example, they showed that even when you take an infant and at a certain age put them into a really high quality foster care, they cannot actually increase their gray matter. They can increase the white matter, so they can increase the number of myelin sheaths, but not the amount of cells. So they're stuck with the small brain they got from the real deprivation as a young child. So there is some kind of limit from deprivation during the early period. I mean, we don't need to talk deprivation. Any kind of trajectory then may stop at a certain point. There's no chance to then grow past that.
Interesting. Thank you. Didn't think about that. Yeah.
Why do you think the ASQ performed that better at determining the most vulnerable group than your mothers without education? I think you showed that data, right?
Yeah, we didn't find it so you're absolutely right. The ASQ did better than the maternal education did not show consistent interaction effects, and neither did wealth.
Yeah.
I wish I knew. I wish I knew. It's telling you something about the child that's not captured in the education and or wealth. And but my hope is that once we understand more about the maternal context and the home environment, in terms of the books and toys and outings and all that family care variables, that could explain more. But I do think it's notable that the ASQ is explaining much more and also identifying children who then can benefit from that kind of cognitive stimulation. Yeah.
Is there a way to go back to the other study in which you had, I guess?
No. I want to hear that. Finish that thought.
Figure out whether if you went back to the other studies, there was lack of maternal education. They predicted whether there are ASQ-like
Yeah, I
in
mean,
that
it's a
are
great
there?
question, and as a matter of fact, it fits right in with a very big global initiative to try and understand what it is that we can identify about kids in that 0 to 2 period that can then be significant predictors. So there's a meeting coming up in April with several people with data sets from around the world that have measures of children's development from 0 to 3, and then also some kind of measure from 5 to 8, to say what items from this test are actually really predictive of what we know about performance at 5 to 8. So, which isn't to say that we would use a whole ASQ, but we might be able to pick out which items from the ASQ have the most predictive validity, predictive power. Yeah.
Just a follow-up to Prudette's point. I'm wondering if the availability of services in general changed with the program. In other words, like what can they buy with the money that they receive?
Mm-hmm.
Do they have available quality of doctors and medical service? They always had available, but they didn't have the money before, and then they received the money, they could access that, or maybe they could not have access to that like, in the community. And what do they do with the money?
So you're asking what did they do with the money and how did access change to medical services
Yeah.
and so we don't have a great amount of information on what they spent the money on in Mexico, unfortunately. We do know some evidence that it was spent on more and better food. And we have some evidence that it was spent on assets such as cows, goats, living assets, which suggests that it's a more sustainable program than some people had anticipated. Because if you're investing in assets that are then returning, for example, milk or other eggs that a child could eat, that's a more sustainable type of intervention. But your question about the healthcare and whether or not those access changed, the program, because it has a requirement that children have to visit the doctor, it absolutely necessitated the facilitation of being able to go to the doctor or go to school. And this is because kids who couldn't couldn't fulfill the obligations of the program couldn't then be enrolled in the program. So for example, in Honduras, they started making mobile health clinics that would go out so that the children could fulfill their requirements. And it has certainly inspired the supply side investments, because I think what you're getting at is that the program can only be as good as the supply side investments. If you don't have it, this is why this is a program that's very popular in Latin America, because there's the administration. If you think about all of the necessary administrative data that you need to collect, whether you went to the doctor 5 times last year, whether you went to school 20 times each month, this requires teachers to keep track, doctors to keep track, all that information to go to a centralized database which says whether or not you get your money next month, if your kids complied with X, Y, and Z. So this is why a program like this can't work. There's only been a handful of examples in sub-Saharan Africa, and most of those are actually trying to promote HIV, staying HIV negative or STD negative. They're very specifically about reducing adolescent pregnancy or reducing HIV risk, and not this kind of massive infrastructure and a bigger social program. That's part of the reason that a lot of them are focused in Latin America and other countries that have the wherewithal and the capital to be able to fulfill the requirements of the program. Did that answer your question?
And just another thing, I was just wondering if there could be spillover effects in the randomization among the
Yes. So.
how close the community.
Yes, so she was asking about spillover effects. Now we can't really look at spillover effects because all communities are enrolled. But there were people who early on, when the program hadn't been rolled out yet, who looked at spillover effects and found that there were. But that's part of the reason that this very early evaluation that started in 1997 picked 7 states that were far enough apart, and then picked communities in those states so that you wouldn't have to deal with the spillover effects. And now we can't answer that question because everybody's involved. Everybody's been rolled in.
Thank you very much
Thank
for
you.
joining us